Ladies and gentlemen, good evening and a very warm welcome to this online panel event from Médecins Sans Frontières. My name is Robin Lustig. I am going to be chairing this event for you this evening. As you can see, we're calling it Babies Don't Wait, bringing new life into the world during a pandemic. We're focusing tonight on the work done by MSF's teams of midwives, nurses and reproductive health specialists around the world. As you may or may not know, 2020 has been designated by the World Health Organization as the first ever international year of the midwife and nurse. And that was even before, of course, the COVID-19 pandemic struck. As you probably know, MSF specializes and has done for many, many years on providing medical assistance to people who've been affected by conflict, by epidemics, by disasters. It also, though, does a huge amount of work in reproductive health and maternity programs around the world. Every year, they assist something like 300,000 births. So this is a hugely important part of the work that they do, and that's why we want to focus on it tonight. I'm going to introduce three speakers to you during the course of the next hour or so. I will introduce them as we go along, and you will have a chance to ask your own questions by using the Q&A facility on Microsoft Teams. You will see a little icon which has a question mark in it. If you click on that, you can then type your question, and I will see it and I will throw it to one or more of our speakers. So without further ado, let's get going. Thank you again for being with us tonight. I hope you will find this an interesting event. Before I introduce the first speaker, though, we have a very short video to show you. Here it comes.
Hi, I'm Laura, midwife and women's health advisor.
I'm Melissa, nursing advisor with MSF.
Did you know that there are over 20 million of nurses and midwives globally?
And over 50% of medical staff in MSF are nurses and midwives.
2020 is the International Year of Nurses and Midwives.
We work with people at every stage of their lives, in hospitals and in communities.
And we want to be there with our patients as leaders, clinicians and innovators.
Join us in celebrating International Year of the Nurse and Midwife.
Bon anniversaire des sages-femmes et des infirmières.
Men shojahun teteflo mana.
So there we are, just a little taster of what you have in store. Our first speaker this evening is Eva de Plecker, who is a sexual and reproductive health advisor for MSF. She's joining us from Belgium. She's been a midwife for nearly 20 years. She's been with MSF since 2004. She's worked in Rwanda, in Ethiopia, in Indonesia, Darfur, Zimbabwe, Democratic Republic of Congo, and Haiti. She since 2011 has been working in Brussels at the headquarters of the MSF operation, and she will provide us with an overview of the maternity work that MSF does. Eva, over to you.
Okay, thank you, Robin. Thank you for the introduction. Really looking forward to the event and the opportunity also as us midwives that we can present our experiences of COVID-19 on sexual and reproductive health. Next slide, please. Next slide. So first of all, a short introduction on what are now the different sexual and reproductive health activities in MSF. So first of all, we talk about deliveries. This can be vaginal deliveries or cesarean sections. And as Robin already mentioned, in 2019, MSF conducted more than 302,000 deliveries, of which 9% were cesarean sections. We also offer care for women throughout their pregnancy. This is what we call antenatal care, the care that we provided after delivery for women and their newborns. Also safe abortion care. This can be a termination of pregnancy on request, but also treatment for abortion-related complications, and these are always linked with contraceptive services. Also the care that we provide for sexual violence care, and some of the projects also offer screening for cervical cancer and vaccination. PMTCT is a prevention to mother and child transmissions. This means the testing of mothers throughout their pregnancy for HIV and also adhering them to care. Also the care that we offer for sexual transmitted infections, fistula care, and We also offer care for women and girls that were exposed to female genital mutilation. Next slide, please. So in MSF, we have our sexual and reproductive health policy, and this is really a key document for us as midwives. It gives us clear guidance on how we should organize our sexual and reproductive health activities in the field. The document is existing since years. It was revised in 2014, and it has actually 2 chapters. One of them is on reproductive health. As you saw on my first slide, there are actually a lot of reproductive health activities, so it's important for the field also to know what are now the activities that have a direct impact on maternal mortality, what are the activities rather with the preventive action, and what are other areas of involvement, as for instance STI or cervical cancer. And the second chapter is about all the care that we provide related to sexual violence care. This is of course very brief, because only on sexual and reproductive health we can give a whole lecture. As you know, today is about COVID-19, so I will now zoom in on what have been the effects on sexual and reproductive health due to COVID. Next slide, please. So as MSF, we know from previous humanitarian emergencies, for instance, as Ebola, that routine healthcare services can be disrupted. And these stopping or disruption of these healthcare services, they can really be catastrophic, and they can have severe consequences for women and children. Throughout the Ebola emergency, we saw that there was an increase of maternal mortality and child mortality, and this was not really related to the Ebola epidemic itself. It was rather due to the indirect consequences of this Ebola emergency to the influence on these healthcare services. There is an interesting paper that was published by the Guttmacher Institute, and they actually estimated, like, let us say that there would be a 10% decline of SRH services in a particular country due to COVID-19. This can increase the unintended pregnancies, the unsafe abortions, and this paper even states that if you would have a reduction of 10% of SRH activities, this could lead to more than 28,000 maternal deaths. We also know from our experience in the field that in many fields that we are working, that the reduction of SRH services due to COVID was even higher than 10%. So the consequences are catastrophic for women and girls worldwide. Okay, next slide. So what were the other consequences? I think all of us, we have been confronted, and still today, with confinement. And in the field, we actually saw that many women and girls didn't have access to medical services. Also routine like transport was not existing anymore, so it was really difficult to access care. Also, the most vulnerable, women and girls, or even boys that were already in a situation of violence, due to the confinement, it even increased their vulnerability. There is a loss of the social networks, they can't go to school anymore. So this also increased the violence at home, and it also increased their vulnerability. We also saw that a lot of the national healthcare systems had a reduction in their capacity. For instance, I heard from many of my midwife colleagues in the field that some of the maternity beds were relocated for COVID patients, and this made that there was a reduction in the capacity of these healthcare systems. There was also a need to adapt the circuits. You could just not enter the hospital anymore. There was a need to create triage systems, and there was also the challenge to refer women when they had confirmed or suspected cases of COVID. One of our colleagues in Yemen, normally in Yemen we manage normal deliveries, and we would refer women for complications, and this was not an option anymore. From the moment there was a suspicion of being COVID infected, a lot of the healthcare facilities did not receive pregnant women anymore, and this was definitely a concern. There were also a lot of competing priorities. For instance, we give now a lecture about sexual and reproductive health, but if I would ask to my colleagues about on malaria, HIV, malnutrition, there was a lot to prioritize, and there were a lot of competing priorities, and it was not easy. Also, COVID hit hard, and it went fast, and there was also from the very beginning a limited visibility on the activities, and this was challenging. It was challenging for the field to prioritize, and it was also challenging for us, being based at headquarters, to have an overview of what was happening in the field. Okay, next slide. Also, my colleague Jacqueline will present on it, but we had a lack of human resources. Some of our national staff became sick. There was also not the opportunity anymore to send international staff, expatriate midwives. Airports were shut down and there was no option to travel anymore. And as for instance, for the Ebola emergency, a lot of our staff at HQ, they went to the field to support, and due to COVID, this was not possible anymore. There was also the risk of transmission. A lot of our staff were afraid to be contaminated. So there was a need to adapt our services, also to discuss how we are going to do this. And definitely there was a need to train our staff, how to wear the protective material, how to do the hygiene measures, and this required a lot of time and investment. I think COVID really, forced us to be, didn't force us, but allowed us to be very creative, because we really had to adapt our way of working. As I said, normally we would all go to the field and support, and this option was no longer there. The field had to adapt to work with less resources, and we also at HQ had to adapt our way of working. However, we need to say that not everything is negative. There were a lot of opportunities also for MSF to adapt our services. And there was the opportunity to challenge ourselves, like how can we invest even more in self-managed and community-based SRH care. For many of the women could not access our services, so we were obliged to rethink our way of working and to allow that we would provide SRH services closer to community. And the need to engage with women, their societies, their communities was even stronger, because it was very important to spread the message and then sensitize our communities also to make sure they are aware that you could still come for delivery. Next slide, please. So what was done now? What was now MSF guidance and how did we support it to the field? Next slide. So there are actually 4 key documents that were produced. One of them was on how to manage pregnant and lactating women and their newborns. As you all know, COVID is, at the time, it was a new virus. We were learning. So there was a clear need to guide the field on, what is the effect on a pregnancy? Is there a risk related to delivery? For instance, the document also had a flow chart in how do we assess COVID risk in a maternity unit. So this was a very 2-3 pager document, easy to read, also based on WHO recommendations, but really giving clear guidance to the field, like how do we manage now pregnant and lactating women in this pandemic. Next slide. The second paper that was produced was about breastfeeding. There was a lot of fear regarding breastfeeding. A lot of women fear to breastfeed their children, their newborns, because they thought that there is a risk of transmission. So this paper clearly stated the importance of breastfeeding to continue, because indeed there is a risk that a newborn can be infected, but this doesn't outweigh the advantages to continue breastfeeding for the bonding of mother and child, and also because of the increase of immunity and the reduction of child mortality. So also the document, one back still, also the document gave clear guidance, because it's easy to say you still need to breastfeed, but if a mother feels uncomfortable or she's coughing, should she wear a mask? Should she wash her hands? What are the risks related to her newborn and her husband? So this was also very important. And this was produced by the nursing working group, the pediatric working group, and the reproductive health working group. Next slide. And then, as I already said, the importance to maintain these routine reproductive health and sexual violence services, they should be maintained. So this paper gave clear guidance to the field, like how do we now reorganize these existing services based on the nature of this specific humanitarian emergency. So actually we grouped it in 3 categories. The first categories were activities that are essential. They are time sensitive. They should be continued. You can't say to a woman if she comes to deliver, maybe come back in 1 or 2 months. So emergency obstetrical care, newborn care, safe abortion care, anything related to abortion-related complications, contraception, and sexual violence care, these ones should be maintained as much as possible. Then we had the second category, and the second category are rather the preventive actions, like antenatal care and postnatal care. Here we also said ideally they should be maintained, but they can also be adapted or reduced if needed. And then the third category were activities that we are classifying as non-acute, gynecological visits, and these could be suspended. And this is not so different to what we are doing currently in Europe. Maternity services are kept open, antenatal care services are reorganized, and non-acute consultations like gynecological, they are postponed. Next one, please. Voila. So what kind of solutions and adaptations were now made? For instance, a lot of our teams, they adapted the antenatal care consultation. So we try to identify what are the low-risk pregnancies, and the low-risk pregnancies, they were followed, for instance, by consultation by phone or by other means. And we try to identify the higher risk pregnancies, and then we still invited them to our services, and we allowed that, you know, there was the social distances, and this allowed that women could still come to our services, but there were less consultations to be done. For instance, for family planning, we recommended to have longer refills regarding medication. Normally we would give 2 or 3 months medication, and now with COVID we said, you know, at least we need to assure that women can have, for instance, oral contraceptives for 6 to 9 months. Jacqueline will also explain her experience from COST in Afghanistan, that many of our maternity services, they were also confronted with the fact that we had to reduce the number of caretakers joining women to deliver. And also there was the need to organize isolation wards inside of the maternity to isolate the suspected cases. Regarding self-abortion care, here, even before COVID, MSF already started to demedicalize safe abortion care. It's mainly provided by nurses and midwives. We don't do a systematic and ultrasound scan, but for many of our projects, there was no option to come anymore to request safe abortion care. So some of our teams, they reinforced how to implement self-managed abortion care and to provide it closer to the women's house or their communities. Next slide. So regarding sexual violence and intimate partner violence, there a lot of our teams, they used mobile technology. So hotlines were used. When you were exposed to sexual violence, you could call this number, and then you were guided through how we can provide care. Some of the care was done through community-based. In each community we have, sometimes it can be a traditional birth attendant, or it can be a community leader that made the link with our medical service, and some of the care was even provided at home. Definitely here there was a high need to continue to work on our health promotion messages, and it was also integrated from the very early onset of COVID to really emphasize on the importance of sexual violence care and also the risk of the increase of sexual violence care due to COVID. And the focus was definitely on the 120 hours, because the earlier the victim comes after the assault, the more you can actually assure that there is no HIV transmission, there is less risk of being infected with sexual transmitted infection and also not to become pregnant. And this was definitely an issue with confinement, because it was not so easy for all these women to reach care. Next slide, please. Voila, now I think you can click a few times, because I think there are still one more, voila, thank you. So as I said, it challenged also our creativity. MSF USA really produced a very interesting communication package around women and girls that they face greater dangers during the COVID pandemic. You can find the link here below. It's a very informative communication package, and it also includes live COVID talks regarding sexual and reproductive health. It also includes a podcast where you can hear the voices from the field, where you can hear the experience of Honduras and South Africa. And as I said, yeah, we were forced to to be creative, and a lot of webinars were organized to promote these guidance papers and also to increase or to strengthen communication with the field. So here you see in the very small corner our colleague gynecologist Severin, that you will see later on also in the video of cost. And we moderated a webinar to explain all these protocols and to allow the field to ask questions. Next slide, please. Voila, and now I think more important, we are going to listen to the voices of the field. I want to also end by saying that we are super proud of our national staff midwives and the teams in the field. I think it has been very difficult times, and still today. Many of us as expats, we could not go to the field, but I think our national midwives were there, they stayed there, they worked hard, and I think it's important to say that it's thanks to them that the essential SRH services could be maintained and that women and girls could access care. Thanks for your attention, and then I will bring it back to Robin and Jacqueline. Thank you.
Thank you very much, Eva. That's a fantastically useful overview. Just one question from me. We hear relatively little from the world's poorest countries about COVID-19, and I think many of us perhaps have the impression that there's rather less COVID-19 in the south as there is in some of the world's richer countries. Is that in fact the case? I mean, can you give some idea of how prevalent the coronavirus is in the countries where MSF is operating?
It is definitely prevalent. It is true that it hit later. I think the COVID emergency started rather, as you all know, in Europe and in Italy and in Spain. However, I think in the field it's very difficult to give the clear and the exact data because we don't have the same screening options. However, I know from a lot of our countries like South Africa, Latin America, as we all know, as Brazil and all other countries, that there are a lot of COVID cases. However, they are not confirmed always, and it's very difficult to do the testing and also to offer treatment because we are not as well equipped as in Europe with these intensive care units. But it's definitely happening, and we are definitely witnessing this in the field, yeah, for sure.
Okay, thanks very much, Eva. Well, as Eva mentioned, our next speaker is going to talk to us a little bit about one particular facility in Afghanistan. But before I introduce her, we do have another little video from that facility in Khost. So let's have a look at that first.
My first mission was in Africa, in Sierra Leone, and my last mission was 2 months ago in Afghanistan, in Khost, where I've been returning in total 9 times. The first time I went there was 6 years ago, in 2012, and I've been returning every year at least once. And it's also very special for me personally to have been there since the beginning of the project. I physically saw the first baby being born there, and now MSF is managing in a very special place on the world map, a maternity where we manage 2,000 births a month. Afghanistan is one of the countries with the highest maternal mortality and also neonatal mortality in the world. And when MSF went to look into the Khost province, they saw that many mothers unnecessarily died and that there was also a severe lack of qualified staff. So no doctors, very few midwives, very few hospitals, and many mothers and babies unnecessarily dying. And that's why MSF decided to go there. So first of all, MSF is offering quality care and for free, which is well, a major reason why women and families want their wife to deliver there. And I think also one of the major factors that played a role is the fact that it's a hospital women for women. So almost all of our staff are female, and the Afghani culture, especially in the rural areas, is still with a very strict separation of the sexes. So from the moment we opened, we said all midwives will be female, all doctors in the maternity are female. And so this also offers the women a context where they feel at ease. But in the hospital, it's like we are in a kind of island of peace and quiet, and women taking care of women, a sisterhood of women. So they talk to the patient and they say, "Yehore," which means, "Hey, my sister." So just a way of addressing the patient is, "You're my sister, I will take care of you." This also has as a consequence the few times that unfortunately we lose a mother a year, the staff is also very much affected. The staff has tears in their eyes, are crying, are sad together with us and together with the family. In Europe, or where I work, we have the impression that Afghani women are victims. All this is partially true, but I also met very strong Afghani women who are doctors, who are studying, who are really good midwives, who save babies and mothers every day. This is something you never hear in the world news. Everybody who has worked there will say the same thing, is you plant seeds and you get flowers. You give people opportunities and they take the opportunities. And this is very gratifying. I teach someone the first cesarean section, and then 1 year later, she's doing everything herself during the night, just calling me to say, "Hi, I'm going to do a cesarean section." And I'm asking, "Are you fine? Should I come?" And she says, no, you trained me. I will be fine. If there's any problem, I will call you." And usually she doesn't call. So this is really gratifying. Yeah, you plant seeds, you get flowers and the occasional rose.
So there you are, just an idea of what it looks like and sounds like at that facility in Cost. As I said, our next speaker has also worked there. She's Jacqueline Scarbolo, who joins us from Italy. Jacqueline's been a midwife since 2006. She worked for 9 years in Italy, then came here to the UK. She's been working for about 18 months as a midwife in the NHS. She's done a number of trips from MSF to all the best countries in the world, to Afghanistan, of course, to Iraq, to Syria, and to Pakistan. So, Jacqueline, over to you.
Thank you, Robin. So, my name is Jacqueline. A little bit more about my work as midwife supervisor in Coast Maternity Hospital in Afghanistan, and how was our life pre and post arrival of the coronavirus pandemic. It was a testing and challenging time that forced us to adapt and reevaluate all our standard practice. So I've been working, some information about me. So I've been working in the last 4 years in the field, mostly in night security and risk context, largely in CMONG project. It means Comprehensive Emergency Obstetric and Neonatal Care Project. And previously worked more than a decade in Italy and UK. Amongst other jobs, I've worked in search and rescue operation in the Mediterranean, and I volunteer in Kenya and Ethiopia. My role varies based on the need of the project, focusing on clinical supervision or coaching or department and implementing sexual reproductive health activities. Can we go on with the slide? Recently, exactly end of July, I came back from my mission in Afghanistan, and I was based in Khost. It's the largest city in the southern part of the country, and it's close to the border with Pakistan, with over 500,000 inhabitants. My mission lasted nearly 9 months. And can we go on with the slide? Since the beginning in 2012, our MSF maternity became one of the 2 most important providers of obstetric services in the province. And the only other additional maternity hospital was Khost Provincial Hospital. Our medical strategy before COVID was to focus on complicated deliveries and direct obstetric complication. For example, antepartum and postpartum hemorrhage. It was partially achieved by supporting 5 community health centers in the surrounding area and by cooperating more closely with KPH with the referral of normal deliveries. Despite the support that we have given to the CHCC, since the opening of the project in 2012, our mission goal to focus more on complicated deliveries remain really challenged, since the number of deliveries increased exponentially over the years. Just before COVID, we had approximately 1,900, 2,000 deliveries per month. Can we go on with the slide? Every project, every MSF project is run predominantly by national staff who are there all the time, and then only few positions are reserved for international staff like me, who come and do long or short mission, and then we go back home. We can go on with the slide. Now I would like to walk you through the journey of the patient inside the hospital before COVID. So we had an admission area, then an obstetric department where the patient were admitted according to specific criteria of admission. Mostly they were in labor or presenting obstetric complication. Then we have 2 delivery rooms with total 9 delivery beds and 2 big labor rooms. And next to it, we have an operating theater where we were performing cesarean section and rarely emergency hysterectomy. Our rate of cesarean section was successfully low, roughly 5%. Then the patient was going to the IPD department for the postpartum and post-abortion care. The IPD was made up of big rooms with an average of 15-20 beds, and they were divided according to the type of delivery. Just behind the IPD department, we had a neonatology department with around 30 beds, and we had an average of 140-160 admissions a month with a bed occupancy over 100%. We had also an area designated for the female caretakers, and it was all located close to the IPD. So all the mother-in-law were able to stay overnight inside the hospital, and post-COVID, this area became the isolation department for all the suspected cases. We had also our compound for the international team where we live and was linked to the hospital, and in a few minutes we were able to reach by foot the hospital for any emergency during the day and during the night. From my side, I was in charge to supervise, train, and mostly support all the staff of the obstetric department. And when I arrived in November 2019, the national team in OBS was assembled by 71 midwives and only 3 national gynecologists. And only the last month we were able to hire other 2 doctors. When my first impression when I arrived at work the first day, it was to be inside the village. There were lots of patients and caretakers walking around with newborns, food, bags, and we could hear just outside the OBS the calls of the names of the husband. In fact, the male caretakers were usually waiting outside the hospital to be called to sign the consent with a fingerprint for any procedure required for our female patient. For example, an emergency cesarean section for hemorrhage. Our patients were coming not only from the city, but also from rural areas where no facilities were available with operating theater. In the countryside, births are typically home births with a traditional birth attendant, and the mothers are only tended to come to the hospital, so to our facility if there was a challenge birth. Pregnancy and being a mother have essential importance in our Afghan women's life, and very often they have many children. I'm talking about 8, 9, 10 children delivered by each woman. And often we could see patients that were running from admission hand by hand with one of our midwives to the delivery room because it was baby number 7, 8, and they were coming really fast. And usually the men, they were waiting outside as it was considered a field of women. About a bit of our patient. So traditionally, a wife moves to the home of her husband's parents after the marriage. And mostly they live together with the mother-in-law, Paiwaz in Pashtun. The attitude of the members of the family towards the pregnant depends on the education level of the family and on the sex of the expected child. So if the expected child is a son, she's more supporting rather than a daughter. It was one of our rules to the gender of the baby during an ultrasound to try to avoid any discrimination. Never forget the mother-in-law, because they were running after all of us as medical staff, begging to check constantly their patients, and often they were quite demanding. They were waiting for their grandson just outside the delivery room, anxious to wrap the baby according to the local costume, and then taking the patient in rush at home. Our patient, usually they were admitted for less than 6 hours for a normal delivery. Before COVID, so the mother-in-law was following the patient in all her steps inside the hospital. And for any decision regarding the mother or the baby, the mother-in-law was always in touch with the husband outside to even on decision about, for example, family planning. What happened with COVID? So we can go on with the slide. So everything changed when I came back from my holidays in March. When I came back, the project was started to our COVID-19 response. And in cost, the first case was confirmed only on 24th April, exactly 2 months after the first case confirmed in the country. We started with the implementation of a triage and screening at the gate. We were measuring the temperature and asking triage questions about symptoms, contact, and travel history. And if one of these topics were positive, the patient would have been admitted in the isolation department and considered a suspected case. We organized an isolation department from scratch. It was the ex-caretaker area. It included 8 beds for labor and postpartum, plus 2 delivery rooms and neonatal room, as you could see from the slide. The patients were used to be accompanied by their female caretaker during their hospitalization as culturally required. But to reduce the flow of the people in and out of the hospital and to avoid all the crowding, we decided to stop access for them inside the hospital. And it was a big challenge. Our field coordinator had constant meeting with the elderly of the community to receive feedbacks. These restrictions are thought also to be one of the main reasons why we suspect we saw a reduction in our admission since April. And other factors at the beginning were related also to the partial lockdown and roadblocks. During COVID time, we deliver training about safety measures and infection prevention control rules for all the department, specifically in hand hygiene, use of masks, social distancing, that was quite culturally difficult to accept. Training about dressing and undressing for PPE, so personal protective equipment. We removed part of our beds to create more space between each patient. Regarding the international medical team, we changed our roster to try to increase the presence in the hospital on the weekends and the nights, to try to provide more support to our national staff, mostly working on suspected cases, COVID, and in isolation. All our holidays were cancelled, and due to travel restriction, also the number of the international staff was reduced. We were confined inside the compound without being able to see anything outside. But one of the major challenge was the need to be cautious about our staff. Staff suspected or confirmed COVID, because we need to reduce for the transmission. So all the staff who was reporting symptoms were investigated through a huge contact tracing and screening before coming to work. During the first half of June, we had a cascade of national staff. I'm talking about more than 100 staff, including office team and logistic, that they were sent home due to contact or symptom history. And by mid-June, around 40% of the medical and paramedical staff on roster was in home quarantine and isolation. It became quite challenging to cover all the roster with only a few staff available. And also for the international team, we became also challenged when 2 expat medical colleagues were preventively evacuated from the project as starting to develop symptoms. Due to this sudden decrease of staff available, we also decide to reduce our admission criteria for 2 weeks until the end of June. So we were receiving only emergency patients in unstable condition. We needed to change and adapt quickly because we needed to try to preserve our medical activities. And another main challenge was the difficulties to get patients tested by the local surveillance team that was allocated to at the Coast University Hospital, but was not really working very well. Theoretically, it was the hospital for the referral of suspected case. So what we decide to do? So one of the main solutions to try to keep running the hospital as much as possible contamination-free was to organize accommodation for all the staff on hospital ground. So 7 days shift, living in the hospital, working in 2 teams, 12 hours, 12 hours. And we decide to close one of our IPD department and reorganize all the setup of the hospital. So we arrange dormitories for all our staff. It was quite a big change for all of us, mainly for our national staff and for their family to adapt of this new system of the 7 days, 7 days. And was the only way to through whom we could be still available to guarantee safely obstetric and neonatal care to all our patients. And this system was still in place until July when I left, and our number of deliveries was around 800 a month. And now next slide. Okay, I love this picture. So this picture was taken on 17 June 2020 and shows the heaviest baby born in Coast Maternity Hospital since the opening 2012. Sorry, the second heaviest baby born was my first, but was the second for Coast Hospital. And I also remember this day because we had a very special patient that I remember the story really well. So we had this young, beautiful girl that she delivered in the car on the way to arrive to the hospital. She delivered a preterm baby. And immediately she was brought to the delivery room and we realized there was a second baby and she didn't know. The first baby was admitted immediately in neonatology, and the second baby appeared with malpresentation and in fetal distress. So the heartbeat of the baby was not going well. The mother started to bleed profusely. So we rushed immediately to the theater, but fortunately, without any surgery, we were able to deliver the baby through internal maneuver. The story was not finished. So our baby unfortunately died after a few hours, and the mother started to have the postpartum hemorrhage and cervical tears. During the management of the postpartum hemorrhage, we discovered she had a rare uterus malformation. The name is Didelphys uterus bicollis, and practically she had 2 uterus, 2 cervix, and 2 vagina. She received lots of blood, and she had also an infection postpartum. But after weeks and weeks of antibiotic therapy, she was really able to recover really well, and she stayed with us for almost a month with her baby in neonatology due to prematurity. She was our princess, and I'm really glad we could offer her the best treatment for such an unexpected and challenging time. When I left Coast, I really left part of my heart there, and I miss all the Afghan team who became a second family and shared joys and really rough moment with me. Despite all the tiredness, I'm really glad that we could keep running our maternity center and we offer the best care we could to all our patients. Thank you so much.
Jacqueline, thank you for that. I just kept looking at that weight indicator on the scales there, 7 kilos for a newborn baby. That is one heck of a baby. Thank you very much for that. Our third speaker joins us from Sierra Leone. Her name is Fatoumata Soumaila. She qualified as a nurse back in 1993, joined MSF in 2004. She then retrained as a midwife in 2010, joined MSF then as a midwife supervisor, and she's about to be transferred by MSF to work in Bangladesh. And now Fatoumata isn't able to join us live, but she has recorded a presentation for us, fortunately. So let's hear it now.
Good morning. I'm presenting on the topic experience of COVID-19 in Hinistas Community Health Center, my 91 Tonkolili. My name is Fatmata Sumaila, midwife. About myself. My name is Fatmata Jebe Sumaila. I've worked for MSF for 16 years, working with MSF OCA and MSF OCB. I'm initially working as a nurse, and for the past 8 years, I've worked as a midwife. I worked as a state-enrolled community health nurse in Godama Referral Center in the maternity ward in Bhutan since 2014. Currently, I am a midwife supervising in Hinista Community Health Center in my 91 Tonkolili District, Yoni Chiefdom, Northern Province, Sierra Leone, West Africa. I joined MSF OCA in 2016 and currently working at Hinista CHC. Before COVID-19, I was working as supervisor for the Hinistas Community Health Center maternity, supervising antenatal care, delivering, postnatal care, and sexual and gender-based violence. It typically involves creating a roster, ensuring the workplace is clean and well-stocked with medication and equipment, supporting junior staff, helping in difficult deliveries or cases, and organized training for staff. I am passionate about midwifery and I enjoy working for MSF because I believe in the MSF principles of humanity, neutrality, impartiality, and independence, and improving health care for women and babies. I have delivered over 2,000 babies. This is a photo of me working in Hinista CHC with my colleague Mariatu. The most rewarding delivery I was involved in involved a woman coming to deliver her second baby. She was 4 centimeters dilated when she arrived to Hinista CHC with cord prolapse. I called for an ambulance to take her to Magroka Government Hospital, while she could be better managed. Whilst I was waiting for it to arrive, I used my nursing and midwifery skills to support the woman and her unborn child. She progressed to full dilatation and delivered a healthy baby. My experience as a midwife during Ebola. I was working in Bhutan with MSF OCB during the Ebola outbreak in 2014 to 2016. There was an increase in patient flow, and nurses did not adhere to infection prevention control precautions. Some of the patients did not show signs or symptoms of Ebola, and therefore some of the nurses became infected with the disease. 6 of the nurses died. The maternity unit was closed due to the belief that body fluid, including blood and amniotic fluid of patients, contained the virus. And later, the whole hospital was closed down. This is the map of Sierra Leone, indicating Tonkolili district and my 91. And this is Hinistas Health Center. You can see the main building and the labor ward. Hinistas Community Health Center. Basic Emergency Obstetric Neonatal Care Center. Attached to this center is 29 peripheral health units, 8 of which are supported by MSF. MSF started supporting Ministry of Health and Sanitation since 2016. Total of 56 staff are in Hinistas CHC. 16 are attached to maternity unit. Hinistas CHC has no doctor. Because of that, no cesarean section is performed. And from Hinisters to the referral hospital is 119 miles, which is 238 kilometers from Hinisters to Magoka Government Hospital. Before the peak of COVID-19, antenatal care, you can see the figure of antenatal care that was done, which is 425, deliverance 58, postnatal 149, family planning 207, and sexual and gender-based violence 7. During the peak of COVID, and even now, the number in the table shows a decrease in deliverance and number of attendees to the clinic in Hinisters. The number of SGBV cases in May is the highest for this year. This is because a new focal on the table, you can see a peak, which is April to June, and at the bottom of it, you can see the rainy season. This makes us not to show the actual figures because we can't tell whether it is due to COVID or due to the rainy season. During the peak of COVID, we noticed that there is low turnout of patients because the community believe that nurses receive money to inject people with COVID-19. The impact of this caused women to give birth at home. Only women with complication will come to the health facility to deliver. How I feel to be a midwife during COVID. During COVID, the HR challenges, we have HR challenges, which is staff off sick, some in quarantine and some in isolation. Because of this, midwives have to work long working hours. Even though we were having COVID in my 91, but we didn't have any positive pregnant women with COVID. And mask is a barrier to communicate to the women because they cannot see our face. The PPE is so hot and sweating, not enough PPE. In labor, we don't have social distance. I witnessed a woman coming in late in facility and with more complication. Restricted number of birth partners, more times for each patient. I don't feel scared working during COVID. This is because I used to work during Ebola, which is more scary than COVID. And in Ebola, you don't know who is infected or not. So because of that, I was not scared since I already know how to work during infection time. And because of this, we are having low rates here. But during Ebola, 6 staff died. What is happening now? The number of births still reduced. Staff are now back at work. More staff than patients. This is because we are having less patients coming in and the staff are still at work and the numbers still remain the same because we know when the COVID reduce, we still need this staff. Supply chain rupture affecting family planning. Because of COVID, materials are not allowed to come to the country and those we have in stock, we've used everything. So because of that, we are having problems with rupture and not only family planning commodity, even other materials are ruptured. No recorded increase in maternal deaths in Hinisters since the beginning of COVID and even now. COVID-19 has been a challenging and has affected our work. Now we will continue to engage with the community to encourage women to come to Hinisters CHC to receive health care. We hope to increase the number of activities I'm delivering. I have been offered a midwife activity manager job in Bangladesh, and I will be starting at the end of this year. Thank you for listening.
Thank you, Fatmata, for that very useful sense of perspective. I thought Ebola far more frightening than COVID-19, something perhaps we need to bear in mind. We've got just a few minutes left in which to take questions. Thank you to everybody who has sent questions in on the Q&A facility. You've still got time to send one in if you would like to. Couple of questions about the role of men in providing maternity services. I wonder, Jacqueline, perhaps if I could ask you, in Afghanistan, the position of women obviously has been very difficult for a very long time. Was it your experience in Khost that some women at least had difficulty accessing the kind of services you were offering because their male partners simply wouldn't allow them to? You need to unmute your microphone, Jacqueline.
So from my experience, it's really depending on the level of education of the family. Usually the role of the man is to take the patient to the hospital, but then it's really depending if the patient was coming from rural areas and they were understanding why they need to come to the hospital or not. We had lots of difficulties when we needed to admit the patient to the isolation department. You can imagine that the patient was going to be scared. They could see us with all the PPE, so the personal equipment, and they were see all the isolation where they were kept alone. So most of the time we needed really to explain and involve translators, and our midwives spend really time and care to reassure them that we were keeping them in isolation to try to avoid any other contact with other patients. But definitely the husband has a main role to decide when the patient go to the hospital, and if she really need to be admitted. Without consent, we couldn't admit any patient.
Thanks for that. Eva, can I ask you to add a little bit to that, perhaps? I mean, I remember once when I was reporting from Sierra Leone on maternal health services, some people there were actually providing programs for men in order to explain to them what they were doing for pregnant women and around the births of their children. And I wonder whether that's something that MSF also pays some attention to.
Yeah, we definitely do. I think male involvement is shown by many organizations that is very important to increase uptake of delivery care. Even in MSF, we more and more are conscious of this, and not only related to delivery care. We have, for instance, a program in Lebanon where we actually try to organize information sessions regarding contraceptive care. And one of the feedback of the men were that they found that actually these women health centers are not male friendly. They didn't feel welcome. The opening hours were not adapted to men. So they said, even if I want to join my wife, I can't because I need to go to work. So by organizing these information sessions, adapting the clinic hours, we actually saw an increase of men joining their wives for contraceptive care consultations. So I think, yeah, gradually we are learning more, and definitely, you know, the time of delivery, it's a family event. And I think we all need to reinforce male involvement. And also, as Jacqueline said, to make sure that we clearly explain to them what is happening to their wives.
And do you think that since the beginning of the COVID-19 pandemic, that has actually become more of an issue? I mean, have you heard stories of women being told by their male partners, no way am I going to let you go to a hospital while all this is going on?
I don't know. I don't even know a clear example because of their husbands, but I do know that there has been a fear around COVID. A lot of families, women, men, are afraid to come to medical health facilities. So I do think that COVID had, you know, it was the same with Ebola. I think a lot of families are afraid to say, okay, let us manage this delivery at home. It's safer. We are together. Maybe if you will go to the hospital, you will become sick and then the whole family will be infected. So I think it's rather related to the fear of their wives becoming sick than not for them deciding that they should not be offered care.
Right. Jacqueline, just one question to you from your experience in cost. I mean, the vast majority of births, I assume, are uncomplicated. Huge numbers of births take place in a home environment. I mean, can you actually put a figure on it? I mean, in the area where you were working, what proportion of births were totally uncomplicated, normal, without causing any problems, or what proportion did actually require your intervention?
So most of our delivery, they were normal delivery, and is also one of the reasons why our rate of cesarean section was quite low. One of our aim was to try to get all the complicated, so all the emergency inside the hospital. I would say around maybe 15%, 20% they were coming to the hospital. One positive thing is with the COVID strategy was that we really decide to focus more on this complication because we're really wondering where these patients were going. We need to think that we were only two main big hospitals in the province, and think about quality of care. We were one of the most safest facility. But definitely lots of normal delivery are happening also at home, and we clearly didn't have enough data to understand, mostly in COVID time, what was really going on outside.
Thanks for that. One last question for you, Eva, if I may. This is a question. You mentioned self-administered abortion kits. And the question really is, how readily are these accepted by communities? How widespread are legal restrictions?
Yeah, I think women have been managing their abortions since decades. I think it's not anything new. I think we as healthcare providers, and nurses, midwives, doctors, we are maybe not so used to it, or we don't feel always comfortable with the idea of that a woman would come to request safe abortion care. We counsel her and she takes the tablets at home and she administers also the abortion at home. But our experience in MSF that it's actually a very safe method. There is also a lot of literature supporting this. And we actually see that a lot of women prefer this. You know, a lot of women don't want to be in a medical facility. They want to be at home, at ease. They just want to know how to use the tablets. They want to know who to call when anything would go wrong. And we actually see very, very, very low number of complications. We also know that when we are actually having a lot of safe abortion requests, that it's also difficult to manage them at facility level. So for some of our projects, it was the only way forward to start to offer medication abortion at home. So I think for MSF, we were late on this, but a lot of organizations are doing this. So I think now in MSF, we are making progress and we are learning by doing, but it's definitely based on women's needs and also based on what women desire.
Right, this is the last question for both of you, Eva and Jacqueline, from Robert Baker, who says, I hope Eva, Jacqueline and Fatmata understand how very much their work is appreciated. while they care for the needy, do they have carers for themselves? Do you feel supported? Jacqueline?
I need to be honest, it was a really challenging time, mostly when we were confined inside the compound. But as an international team, we try to help each other. And we had support from the coordination in Kabul and from the headquarters to also help us regarding the guidelines and about any question about any complicated cases. So I know everyone tried their best to support us in the field.
Eva, you've worked in many, many difficult and challenging environments. Did you feel supported?
Yeah, I did. I definitely also had difficult situations, and it was not always gloomy. But I do, you know, what I always found rewarding is the team that you have. You know, you're not on your own. You have so many national staff midwives. You have your colleague expatriate midwives, and together you're strong. You know, if Jacqueline could say how many midwives are working in cost, and each time if we go home, we miss them because. It's definitely the team energy and all the rewarding information and feedback that you get from the patients. This really gives energy. I've never been so alone in my home during home working, but I think in the field I always felt supported. So that's positive.
That's good to hear. I've seen MSF at work in many different parts of the world, and I've always been hugely impressed at the dedication and the work that they do. I think we're going to have to bring this session to an end. So thank you, Jacqueline. Thank you, Eva. Thank you in your absence, Fatmata. Thank you, everybody who's tuned in to this panel event. And of course, thanks to everybody who supports MSF, because as you know, I'm sure it's an organization that is funded almost entirely by private donations. So without your support, none of the work that we've been hearing about this evening could have been done. So thank you for your support. Thank you for your continuing support. The website is up there on your screen now, msf.org.uk/donate. If you want to be kept more informed about the work that MSF does, you can sign up to receive the newsletter, Frontline. There's the joining website there, msf.org.uk/join-frontline. Do keep in touch. Do keep supporting. It is very much appreciated. For now, though, thank you again to our speakers, and thank you as well. Good night.